Hi, my name is Karen Shaw and I'm the Project Manager on the TRADIP study. This is a national study funded by the NIHR Policy Research Programme to assess the impact of prescribing by dietitians and therapeutic radiographers. My presentation today is about the protocol for our national case studies. So I'd just like to give a bit of background about the study. Non-medical prescribing is defined as prescribing by a healthcare professional other than a doctor or a dentist. And there's a number of different groups who have these rights: nurses, pharmacists, and many allied healthcare professionals. The two that we're looking at in this study are the ones who most recently had their rights for prescribing changed, and that's radiographers and dietitians. So in 2016, therapeutic radiographers had their prescribing rights increased from supplementary prescribing to be able to train as independent prescribers, and dietitians became able to train as supplementary prescribers. Now, as these are the most recent groups to get these rights, there's not a lot of information about the impact of this prescribing. So the NIHR commissioned this study to assess this, and we have a number of different research questions that we're looking at. The cost effectiveness, because there's obviously cost implications in training people. The quality, safety and appropriateness of the prescribing carried out by these professions. And then the impact on patient experience and their care. And an important element of this is, of course, speaking to patients and carers and getting their views. And also speaking to staff to see what the impact of the prescribing is on the wider team. So our study design involves up to 10 case sites falling into 3 different categories. We'll look at 2 pilot sites. There's one for each of the professions, and as these sites are mainly used to test our data collection tools, we'll have reduced participant numbers. We'll then look at 2 longitudinal sites. Again, this is one for each profession, and at these sites we will be following one individual as they go through their non-medical prescribing training. So we will have 2 data collection time points, one before their training and then a comparison time after they have completed their training, are registered and are using their prescribing in practice. And the comparison between the data collected at each time point will give us an idea of the impact of that individual's prescribing. We'll also look at up to 6 concurrent comparison sites. So this is 3 for each profession, but at these, rather than following one individual through their training, we will look at a matched qualified prescriber and a non-prescriber. So the 2 must be in equivalent roles aside from their prescribing. And we will collect all the data at one time point. And this will allow us to use a mix of geographical locations, and in terms of the dietitians, we'll also use a mix of community and hospital-based care. Normally for a case study we would attend the site in person and collect data that way. However, due to the COVID-19 pandemic we're not able to, so we've developed a number of data collection tools to allow us to continue with the studies but collecting everything remotely. So interviews will continue, however they'll be done by phone or video call. We'll speak to dietitians and therapeutic radiographers and also their wider team to look at the impact of the prescribing on their role and on the team in general. And importantly, we'll speak to patients to find out their views about prescribing and to look at the patient journey in more detail and find out how that varies depending on the prescribing route. We've developed a self-report audit. So this is an online questionnaire which the participating dietitian or therapeutic radiographer will complete after each patient consultation. It will give us some information about the consultation and also about their medicines management activities. We have a health economics questionnaire, and this will collect financial data which will feed into the cost effectiveness analysis. And we also have patient questionnaires. So these will capture patient views on prescribing, their satisfaction with the service that they're receiving and the information about their medications, and also other information such as their quality of life. We will ask the site to copy and anonymise a small selection of patient notes. These will then be assessed by independent experts to review the quality and the safety of the medicines management decisions that are being made. And we'll also ask the site to send us some documentary evidence through. This will give us more context for the data that we're collecting about the service. So as this is a mixed method study, we will be collecting different types of data and these will be treated in different ways. So our quantitative data will undergo statistical analysis by our medical statistician using a recognised statistical software. So this will include data from the questionnaires self-report audits and any quantitative data from the documentary evidence. Our qualitative data will undergo thematic analysis by the researchers in the study team, and this will be the longer detailed answers from questionnaires and from the interviews as well. And finally, we have a health economics team who've developed a health economics model, and this will be used for cost effectiveness analyses, and the data that we'll input into this model will be from the health economics questionnaires, some data from the literature, and also details of patient outcomes, so information on quality of life, waiting times and satisfaction. So as this is the first national study looking at the impact of prescribing by dietitians and therapeutic radiographers, all the data that we collect relating to the financial impact and the effect on the services and patients will go forward as evidence to inform future prescribing policy. So this could have an impact in controlled drug legislation, looking at other healthcare professionals being given prescribing rights, and also looking at the advantages or disadvantages of supplementary versus independent prescribing for different professions. And within the study, the data that we collect will also be grouped together with data collected in other aspects of the study, including our manager interviews that we've carried out, and we will put together a toolkit. And this toolkit will be a way of sharing best practice for implementing non-medical prescribing. So I'd just like to thank you for listening, and if you do have any questions or comments, then please do get in touch. Our email addresses are there. If you'd like more information generally about the study, we also have information on our study webpage, and we are on Twitter. I'd finally just like to thank our funder again, the Department of Health via the NIHR Policy Research Programme. Thank you very much.